Good morning or good afternoon, and welcome to the webinar. We've just begun broadcasting, and we're letting attendees come on in and join the group of panelists that's here today for the webinar. We're glad that you were able to join us today, and happy to have this important conversation with both our panelists that are here today and with all of you who are able to participate with us. Today we'll be talking about medication-assisted treatment and the impacts of the COVID-19 pandemic on access to treatment, and in the state of Iowa in particular. We have a number of panelists joining us today, and we're excited to spend the next 90 minutes with you. So rather than waiting as folks begin to join us, we'll go ahead and get started. Just a few housekeeping items though, before we dive into the content and hear from our speakers. This session is being recorded, and it will be available as a YouTube video following the webinar today, and we will have it posted to our website and distributed to all of you. If you have a comment or a question during the webinar today, please keep your question for the Q&A session at the end. You can place your question in the chat at any time, and our staff will be monitoring your questions and welcoming you to raise them once we get into the Q&A session. However, most importantly, we do ask that everyone keep their microphones on mute for the full session, and keep your video on mute as well, unless you are speaking. To introduce the host organization, we are the Iowa Harm Reduction Coalition, a 3-year-old nonprofit working across the state of Iowa to improve the health and well-being of people who use drugs. We operate a number of programs, including direct services for people who use drugs that work to prevent overdose and infectious disease, training, technical assistance, and capacity building program that offers training for individuals, organizations, professionals, and others in order to increase their capacity to work with people who use drugs. And we also operate a policy program and work to organize directly impacted individuals in a grassroots movement to improve the health of people who use drugs. And so if you're just joining, I'll ask you to go ahead and put yourself on mute. It looks like we have a little bit of background noise here today. So before we begin, I'll also introduce myself. And so as we move through the presentation today, you'll see a slide just like this presented for each one of the speakers as they speak. And again, it looks like we've got a little bit of background noise, and unfortunately, I'm not able to mute individual guests. So I'll go ahead and ask you to mute yourself. So again, I'm Sarah Ziegenhorn, and I am the Executive Director of the Iowa Harm Reduction Coalition, and I'm delighted to be here with you all today to discuss this topic. As we move through the 90 minutes together, we'll go ahead and dive into our speaker portion of the session now. And as we move through our group of panelists, I'll introduce each one in turn as it's their time to begin speaking. We'll move into a moderated Q&A once the speakers have finished, where I'll be asking questions of these speakers. And then once we get into the time after the 1 o'clock hour, I'll invite audience members to ask additional questions. And as time allows, we'll present questions to the speakers that have been posted in the chat box. So please feel free again to submit your questions in the chat at any time throughout the conversation. And ideally, we will have much more time than 10 minutes here for audience Q&A. So without further ado, I'd like to begin by introducing our speakers and diving into the speaker portion. So we have a number of folks today here, and I'm very excited about this group of individuals that will be presenting. So we will dive in first to hearing from Chad today, followed by a number of other folks working around the state. And before doing so, though, I do want to just take a moment to highlight some of our objectives and the goals from our speakers. So to give a little bit of context and a little bit of background, Iowa's overdose crisis has been growing over the past decade, although important to note is that we've seen a significant decrease in overdose deaths between 2017 and 2018, with an 18% drop in the state overdose death numbers. And so while the numbers presented here on the screen are quite different than the numbers that CDC indicates characterize Iowa's overdose crisis, what we do know is that overdose is a common problem in Iowa, fatal or non-fatal, and it's primarily characterized and driven by synthetic opioids and polysubstance use. And so synthetic opioids here indicated in this graph are substances like fentanyl and other types of non-heroin or non-prescription opioids. So importantly, one solution to addressing Iowa's overdose crisis is ensuring that treatment is accessible and available to all who need it and who are impacted by substance use disorders or addiction to opioids. And so the treatment that is available to individuals who are experiencing an opioid use disorder is commonly referred to as MAT or MAT. And so MAT is made up of 3 different FDA-approved medications: methadone, naltrexone, and Suboxone. And the effects and the impacts of these medications are characterized and described in recent study from earlier this year that was published in the Journal of the American Medical Association by Dr. Sarah Wakeman, who's an addiction medicine expert at Harvard University. And so I'm sharing here a summary from her about a paper that they released in a study that they undertook of a very large sample of individuals who were engaged in treatment for opioid use disorder. And what they found after looking at all treatment options available, including intensive outpatient treatment, outpatient counseling, detox, inpatient residential treatment, as well as treatment with the 3 FDA-approved medication, and looking also as well at individuals who were not receiving treatment, is that they found that 2 of these medications, Suboxone and Methadone, or buprenorphine, with Suboxone being the trade name for a combination medication of buprenorphine plus naloxone. But what they found is that these 2 medications had significant improvements in health and reduction of overdose for people who were given them. And so you can see here in the tweet summary that Dr. Wakeman has presented a number of the outcomes that they found in this study. But most importantly, they found that these 2 medications are associated with a reduction in overdose and a reduction in readmissions for treatment. The important thing to note here is that these medications, both methadone and Suboxone, are not simply an adjunctive treatment or supplemental support, but they are a critical tool for reducing overdose fatalities. So important to note here is that the regulations around these medications have been changing dramatically throughout the the year of 2020. And so what we have seen is that because of the COVID-19 pandemic, there has been a massive shift in the way in which these medications can be accessed and can be the ways that they can be prescribed. So on March 31st, SAMHSA and the DEA released guidance that allowed for providers to have significant flexibility for prescribing buprenorphine and methadone in new ways and through reduced regulations. And so we'll be talking about what those revisions have been today as we review the effects, and we'll be hearing from the providers here on the call today about these particular changes. Important to note is that there were some changes made before March 31st, and then this marked another revised update from these agencies that gave additional guidance, but made or established the current protocols for practice. So with that, I want to highlight a few questions that we're here to have to explore today. So we want to talk about today, as we hear from our speakers, the impact of the revisions in these regulations on our patients and the community as a whole. So what impact have these revised regulations had on people across the state who are impacted by opioid use disorders, and what impact do they have on our state's overdose crisis, and what role do they have in stopping it? What is the role of MAT via telehealth in eliminating our overdose crisis, finally, in our state? We also will be talking about how providers have responded to the availability to practice via telehealth, and hear about the variation across the state and how this revised regulation has been implemented. We'll be talking about how federal agencies and federal officials can work to sustain or modify or perhaps end the regulatory changes around MAT that exist now. And we'll also be discussing the role of state legislators and state agencies in harnessing these changes to improve access and end Iowa's overdose crisis. So I'd like to begin now by introducing our first speaker. So our first speaker is Chad Fairchild, and Chad is a Davenport native who joins us today to share some background and some information about his experience with accessing MAT as a patient and beginning buprenorphine during the COVID-19 crisis. So Chad, we are extremely delighted to have you here, and I'm so excited to hear from you. I'm wondering if you can go ahead and unmute yourself, if you can tell us a little bit about your experience.
Absolutely. Can you hear me okay?
Yes.
Hi, everybody. I'm Chad Fairchild, and I am delighted to be here, and I'm glad that I found a program that assisted me with getting my life back. I can't express enough gratitude to helping me reach the goals that's all I have been dreaming about through my addiction. So I'll begin with my short bio here, and I began life with sickle cell anemia, and that's a rare blood disease that it causes a lot of pain. You have flare-ups, crises every few months to year, depending on how well you keep your health. And as a child, I had multiple crises yearly. So with that came a lot of painkillers because I had pain often, and throughout my childhood, as I turned into a teenager and got older, I began using my painkillers, my morphine, my Dilaudid, for more of a mental experience, which is where things got carried away. I know you guys can't see me in this off topic, but I would just like to give a face there. I don't know if you can see me. Balla, yeah. I'm so weird. uh, anyways, MAT has assisted me very much getting my life back and changing my medications so I don't have to take a heavy narcotic for my pain, but I can take the Suboxone, which is what I used. My doctor, Lynch, is helping me in clinic, had recommended the Suboxone or the Methadone, and we ended up going with the Suboxone, and it has been working very well. Again, all of my life I was on these painkillers. That was all I knew, and I knew that I needed to get away from it, but it was very difficult with the withdrawals that opiates cause. Um, your body and your mind suffers so much, and some physicians don't understand that. They think that you're just taking these narcotics so you can get high. And after a certain point, which for me was in my early teens, since I had already been taking the narcotics for so long, the narcotics just they don't get you high uh, to a certain extent. So you begin to take it just to feel normal, um, and just to be on um, a baseline every day, which most Americans use coffee or smoke cigarettes or have their ham and cheese sandwich at noon. Um, for drug addicts, they have to use use that drug because they have built that tolerance. I just want to make sure that some of the physicians here understand that some of these people that MAT and IHRC is trying to assist, they aren't out here to get high, and to ravage the world and commit savagery. They're here just to get through the day, really. And if you could assist them with the Suboxone, Methadone, other treatments, I have seen that ketamine has been looked at to help some people and has worked. These medications can help people get back to normal, so they can live in society like everyone else. Another treatment treatment needs a little bit more accessible for addicts, and especially during Corona, I call it Corona season. It has made it has made medical treatment, both in medical assisted treatment and both in my regular healthcare, because of my sickle cell, which I go to Cancer Clinic B at the University of Iowa with Dr. Stephen Lynch. It has made my visits a little bit difficult, because I myself do not want to be in a place that could put me at risk. Every place, of course, can put somebody at risk, but somebody with a low, weak immune system is even more at risk in the hospital, in a hospital where people are going to get treated for their possible corona-like symptoms. So staying out of the hospital has been a huge priority. Luckily, my doctor Lynch on the MAT side has been willing to work with me, and she's done an absolutely fantastic job. Sam also helps out quite a bit whenever I need something. I can just send a text and they communicate very well. If I need to make an appointment, they're always on top of it. So it's for me, they have really gone out of their way to make sure that I get the treatment I need, which everybody should get. And I think there's a potential of that happening if the the funds are available and the doctors that give the treatment are are there and available for patients. So making it treatment more accessible during Corona would probably involve a telecommunication, which is video chats, phone calls. I'm not a doctor, and I'm not um, in the medical field, but I do see some of the things that could easily be changed with um, resources given to MAT or IRHC to make it so these addicts that are ready and willing to change have the accessibility to Suboxone, Methadone, ketamine to get them on the right path to live in society the way that the government wants them to. Sub- Suboxone, I think I went over that decently. Suboxone helps with the withdrawals, and the withdrawals that I feel personally include sweating, weakness, migraines, pain, cramps. It's a large variety of flu-like symptoms that can be really nasty. Um, Not only do they cause physical exertion, but they cause mental as well, and that mental can lead to depression, anxiety, um, elongated stress over small things. It includes a variety of things that nobody should have to go through, especially if somebody was put on a medication because they had a leg surgery or an illness or something, which a lot of people end up getting hooked on drugs because they had a back surgery or because they had a disease, whatever they had to get treatment for. They got put on this heavy dose of medication that they needed at the time. Nobody thinks that you should just stop giving out narcotics, period, because people do need it at times. But yes, the medications can be addicting to some people. They're not out here to hurt anybody, but it happens, and resolving that problem um, should be we shouldn't even really be discussing it. It should be available and easily accessible. I hope that happens soon in the future. Let's see here. I think I think I went over just about everything I had here. I could definitely go into a deeper experience that I've had in my life with the University of Iowa hospital, nurses, and whatnot, if you would like me to, Sarah.
I think let's save that for the Q&A and then for the discussion section, because I do think what you're talking about is really, really, really important for us to talk about today. But yeah, I think it looks like you are right at time. Is it okay if we move on to the next speaker, Chad, and then we can keep talking in the Q&A section?
Absolutely, I am absolutely open to questions, please.
Okay. One quick question for you, Chad, before we go into the rest of the speakers. Is there anything about getting your medication and getting prescriptions and talking with the providers over the phone that has been difficult or made things easier for you, aside from reducing your risk for COVID as a person who's immunocompromised?
So the telecommunication makes things way easier, not just because of Corona and helping me stay out of the way of being put at risk, but my mom does own a couple businesses in the United States, and um, I have three brothers, and we all manage her businesses for her, and I end up getting very, very busy. So being able to text and call or video chat and save me a trip. It takes me an hour to get to Iowa City. I live in Davenport, so it saves me a 2 hour trip uh, waiting around in the hospital, which it ends up being a whole day just for the appointment. So yeah, the telecommunication is such a beauty. And then with Corona, I don't have to be put at risk. And with some addicts, they they end up being a little bit scary and a little bit um, frightish in person. And I think it helps some addicts be able to open up and express their self through the phone instead of having to look someone in their eyes. Me myself, I love to look people in their eyes. I love to be social, but I do know how people feel, um, and and the telecommunication is something that should continue after COVID, in my opinion.
Thank you so much, Chad. I really appreciate you being here, and I'm really glad you're able to share your experiences and look forward to talking more about some of your specific experiences at UHC as we get into the discussion. So I'd like to move on, and it looks like Kyle is not here today to join us and is having some difficulties getting away from work to be here. So we'll go ahead and move on to Dr. Lynch. So I'd like to introduce Dr. Allison Lynch, who is a psychiatrist and family medicine physician at the University of Iowa Hospitals and Clinics, and the director of addiction medicine, where she is a MAT prescriber and a buprenorphine provider. So Dr. Lynch, can you tell us about how the revisions in the guidelines for bup and methadone prescribing have impacted your practice and your patients?
Yeah, absolutely. Thanks, Sarah, and thanks, Chad, because you totally laid out some a good spot for me to then kind of jump in and share my perspectives. I'm going to share my perspectives that I've gained just from being a physician and taking care of people who are seeking treatment for opioid use disorder. And but a lot of my observations and my perspective comes from what my patients have taught me. So I'll try to share the things that they've shared with me and taught me. And I thought it would be useful just to very briefly talk about some of the barriers to MAT that were in place prior to COVID, because it's been a long-standing issue, as I'm sure many of you know. Some of the things my patients have dealt with has been finding a MAT provider and somebody that they can get to. And there are not MAT providers in all communities. Many people have had to travel, as Chad was saying, an hour or more to find a provider. And then the question is whether they are taking new patients and are their hours convenient, and what about transportation and getting there. And some of that contributed to people having to cancel their appointments at kind of on short notice. And so, and then having to reschedule or miss work or spend money on gas. That was just a huge barrier. And then even if you could find a MAT provider, many of my patients have struggled finding a provider that they feel like is compatible with them and will work with them with with what they want out of treatment and what their treatment goals are. And many of my patients have talked with me about feeling punished or kicked out of treatment when they didn't meet expectations or used substances, had a relapse, or missed an appointment. And so just finding a provider and then finding a provider that you work well with has been a challenge for a long time. And then things like insurance coverage and the cost of care have been a problem. And then my big pet peeve has always been prior authorizations for buprenorphine or Suboxone. When we first started the MAT clinic at the University of Iowa in 2017, it would take days to a week sometimes to get approval from the insurance to pay for medication. That's gotten better, and now we can generally rely on getting same-day approval for medication as long as we don't wait too late in the day to request it. And then last year, the Iowa legislature passed a law that allowed us to be able to prescribe tablets of buprenorphine without needing a prior authorization. So that's been a step forward. But we've dealt with things like dose limits and quantity limits, and trying to navigate the medication approval system has been an ongoing barrier. And then we did have telehealth before, but it was restricted to certain sites and geographic locations. It had lower reimbursement. We weren't allowed to start people on buprenorphine with telehealth. And so it just was not very widely available, and it really didn't meet the needs of the health system or of patients or of providers. Okay, so then we got COVID, and I'll just briefly mention to highlight how some of the things that has done for us. So huge changes, massive uncertainty, a lot of effects financially with employment, social systems. Some people have gotten sick with COVID. The tsunami behind the initial wave, in my opinion, is the mental health impact. There's fear of getting the virus, grieving, loss, depression, anxiety, hopelessness. All of this really challenges everybody's coping system and support system and ability just to navigate our lives. And we know that mental health and addiction, morbidity and mortality, or like adverse health effects and deaths typically spike during disasters. So not surprisingly, we're definitely seeing that now. And in addition, just self-care and care for other medical conditions has been disrupted for a lot of people. Another thing that's been a big deal is that the health system has cut back on some of the addiction services that we have been able to offer. And so a lot of residential treatment programs actually either put a cap on the number of patients that they would take, or some of them stopped taking new patients. And of course, in-person mutual support groups like AA and NA could not meet in person anymore, so that had an impact. And then just the social distancing and isolation has had a big negative impact for some people, just as far as how it affects their recovery support system. So I'll just add a little bit more about the expansion of telehealth. So telehealth just kind of blew up over a week or two, right after the public health emergency was declared. And I think it's important to understand that a whole bunch of federal agencies all had to work together to make some temporary modifications of laws around prescribing, privacy, medical treatment, telehealth, and payment in order to make it possible for us to, what is now possible, which is buprenorphine can be provided through telehealth. It can be initiated through telehealth. Telehealth can be delivered to a person's home. That was another new thing. And providers can be paid for telehealth from Medicare and Medicaid more globally, not just with in certain practices or certain geographic locations. And the agencies that kind of all work together to make these changes were SAMHSA, which is the Substance Abuse and Mental Health Services Agency, the DEA, or Drug Enforcement Agency, the Center for Medicare and Medicaid, with CMS, and also the Office of Civil Rights. So all of those had to work together and make changes to make it possible for us to do telehealth with MAT. So by late March, the UIHC MAT clinic switched to doing all telehealth, and that we did telehealth for our new patients and our return patients. The first week we did that, it was all telephone visits, and by the second or third week, we were doing some video visits also. And one of the things we noticed was that some people who had actually contacted our clinic and scheduled to see us, but never been able to make it into an appointment, actually were able to get in, and we were able to have a visit with them over the phone and get them into treatment. I also, some treatment programs turned to video conferencing. So things like residential treatment was still in person, but IOP, or intensive outpatient, was able to be offered through video conferencing. And also with AA and NA and Smart Recovery and other mutual support groups not being able to meet in person, they all went virtual also. And I read somewhere that like every 5 minutes you could log into a new online group globally. So it became actually much more accessible if you could do it through telehealth. So there are some benefits that I've noticed with telehealth. It's definitely more convenient, and Chad talked about this too. Things like not having to take time off of work. Like Chad was saying, I have patients also who either miss half a day or a full day of work, or have to come on their their day off for the week in order to get an appointment. Now I have patients that they just take a 20 or 30-minute break during their work day. They go out to their car and do a telehealth visit with me. So it's much more convenient. And there's also better safety, like as far as the virus goes. People don't have to worry about contracting COVID by coming into a healthcare center. I should say, I feel like UIHC is a very safe place to be, but we know that being out in the community is a risk. I mentioned that it takes less time because people don't have to travel to and from an appointment or deal with parking or that kind of thing. And as a result, we are seeing fewer missed appointments. So it's been much easier for people to make it to an appointment through telehealth than when they had to come into the hospital. I really like being able to see people in their environment. I've seen a number of people like in their home or on their front porch, or a family member maybe walk by or something. I feel like that's been a nice way to get to know a little bit more about the people that I'm taking care of. And there is the potential for like a family member to also participate, which can be helpful in certain circumstances. So now that people have been able to do telehealth, I can tell you many of my patients do not want to go back. The genie is out of the bottle on that. There are a few limitations with telehealth, in my opinion. I do think that an in-person assessment that I provide is often higher quality than what I can provide over video. I still think we can provide high quality care through telehealth, but sometimes I can do a better job if I can actually be in the same room with somebody. There's also issues with privacy for visits. And I think that's come up a number of times where people have told me they don't want to do an online AA group because their kid is in the same room or nearby, and they just don't feel like they have a private enough space to do something that's as personal as a healthcare visit related to substance use. Not everybody has consistent and reliable Wi-Fi or enough data on a data plan to do a telehealth visit. That can be kind of a lot of data. We've definitely had to be creative looking for ways to help people with their devices and the apps that we use for telehealth and just sort of technology support. When people come into the office, we often can offer them things like we check their blood pressure and their pulse. We can do HIV or hepatitis C testing. We can do urine testing. And when we do telehealth, none of those are an option. One of the things that I hope we can talk a little bit about later in the Q&A is that although right now reimbursement is better for telehealth than it was before, it actually isn't enough to keep our clinic viable over the long term if we switched entirely to telehealth with the current payment model. And I do think that human interaction is important. I think it's important for recovery. I think it's just important for human beings. And I think that my relationship with my patients is stronger when I get to interact with them in person, at least part of the time. So I do think there's still a role to have in-person care available, but it can be a great blend to combine some visits in person with some visits with telehealth. So I think there's a few things I would call for, which are laws that would permit the use of telehealth for addiction treatment at all stages of care. We need reimbursement models that support health systems so that moving forward, we can we'll have the infrastructure to provide in-person and virtual care. So we really need to keep both systems going, a bricks and mortar system and virtual technology. You know, our healthcare system is super complicated. It was way complicated before COVID, and adding telehealth into the health system, in my opinion, makes it even more complicated. And so we really need system navigators to help all aspects of the of telehealth and the healthcare system in order to make it work more smoothly. And of course, everybody needs digital access if we're going to be using telehealth. And so many of my patients have phones, and I think there was some concern that not everybody has access to a smartphone, but I think the studies that are looking into this right now show that actually most people do have a smartphone that has the technology to do telehealth, but not everybody does. And we need to find ways to bridge the gap for people who don't have digital access, because it's becoming more and more of a variable in just overall health. Just a couple other things real quick. We also really need to get rid of the waiver requirement for prescribing buprenorphine and instead provide more comprehensive training for all healthcare providers on working with addiction. And we need to get rid of prior authorizations for medications that treat addiction. And we need to keep working on combating stigma. So that's my 2 cents about, I think telehealth has been great, and it's certainly highlighted a lot of opportunities for us.
Perfect. Thank you very much, Dr. Lynch. That was an exceptionally helpful overview of the MAT landscape. And I know that we are a little bit behind between those 2 speakers, but the good news is that we've had a couple of folks not join us from our speaker group, and that the 2 of you shared a ton of extremely important details and information and covered a lot that I think other providers will want, or other speakers would needed to have addressed too. So moving on, I want to hear from Monica Wilkie-Brown, who is the director of a number of grants in the Iowa Department of Public Health that are the federal dollars that have been received to address the overdose crisis in the state of Iowa. So Monica, we are so happy to have you here, and you always are so gracious in accepting our invitations to speak at events and on panels, and we are always delighted to have you join and share your experiences. Can you talk a little bit about how this landscape has impacted providers around the state, given that you work with so many of the individuals who provide MAT? And can you talk a little bit about how this has impacted public health at the state level and contributed to a worsened or improved overdose crisis?
Yeah, so thank you, first of all, for inviting me. I appreciate the invitation to participate. And I think some of the things that we've noticed during this COVID emergency is that, as Dr. Lynch said, you know, the fact that multiple federal agencies were able to coordinate in a really rapid way, especially if you deal with federal agencies on a regular basis, that was really rapid. And so we were very pleased to see, you know, the change in guidelines and the flexibility provided to local level providers, because that makes access so much more possible, especially during an emergency like this. And so we, at the state level, have to interpret some of the federal guidelines, and many of them were written very clearly, and we were able to just pass them right along. So knowing, for example, as Dr. Lynch mentioned, that telehealth was available, and the flexibility added to include telephonic only, you know, just audio services, had a big impact for a lot of Iowans that weren't necessarily able to access the audio video version of telehealth prior. And then also the changes in the take-home dose limitations that apply to methadone, but also the the flexibility with doing the initial telehealth visits for buprenorphine. Both of those added, I think, a level of access that clients really appreciated and our providers really appreciated, so that their employees could also feel safer and be able to continue working and doing their job, serving their clients, but staying safe themselves. So that has been a great addition to kind of the uncertainty and stress during this emergency time. There's even accommodations available for people who, if someone has been quarantined due to exposure or actual positive testing for coronavirus, doses can be delivered to them. So there's a lot of exemptions, I guess, from the regular rules that have been in place during this time. And I think, you know, the fact that this has gone on for quite a while now, it adds to the opportunity to collect information and data about the pluses and minuses. Because as Dr. Lynch mentioned, you know, we have heard both pros and cons of the current model. And I think many of our providers would echo her preference for the option to use telehealth in the future, but also to keep the option of having in-person, face-to-face services provided. Because, you know, for some people, they feel much more open and willing to talk over telehealth, and for other people, they feel very concerned about technology and privacy and sometimes safety. You know, they may be more at risk for having their medications taken from them if they have bigger doses, you know, at any one time. And so I think there's both pluses and minuses that we've seen. But I think we'll have to wait and see too about if there are changes that get maintained after the emergency declarations are over. And so I think that is one of the challenges that we're looking at, and kind of seeing what, if anything, we can do at the state level to buffer, you know, what we can, as those changes may go back to the prior guidelines. I think as far as overdose goes, you know, we haven't seen a huge spike during this time, but we also know that our overdose data, because it comes from the death certificate data that Vital Statistics gets, is, you know, not as timely as some of the more informal reports of overdose, as well as the fact that ours does rely on the coding on the death certificate to include mention of opioid or overdose. And so while our numbers, as you mentioned, did decrease in 2018, we did see a small increase from 2018 numbers that didn't quite reach the level of 2017, but did go back up. So the downward trend did not continue in 2019. And I would say our current trend line, you know, because it's a little bit behind, is likely to either stay even or possibly increase for 2020. So, you know, we're only halfway, not quite halfway through the year, but there are, you know, no indications that it's going down dramatically. And that is, of course, then one more reason that we really need to make sure access is a priority. So I would encourage people to make sure that they're in touch, both themselves and their families, their friends and neighbors, in touch with their representatives at their local and federal level, and share with them, you know, what your priorities are for changes to happen, because that is where the directives come from regarding federal money and state money, of how it can be implemented. So that's what I had to share.
Thank you. That was perfect. Thank you so much. Monica, do you know off the top of your head what the number of overdose deaths was for 2019?
The number, I mean, it kind of depends on how you count it,
Mhm.
whether or not you're counting occurrences within Iowa versus residents of Iowa. But the number that we have that we use most often is 157, I believe. I'm looking at my chart and it doesn't have the total, but it has all the numbers. So
Do you have a number for 2020 up to the most current or current date that you have data for?
I think we were already at 57. I would have to look back at that one. But I think we were already at 57 last time I checked.
Okay, perfect. Thank you so much. Okay, so now I'd like to introduce Jen Pearson, who is the CEO of UCS Healthcare. UCS is a phenomenal treatment organization in Iowa that is based in Des Moines, but has done, and I don't have a word to describe how incredible their work has been to get MAT access expanded around the state into many, many, many communities. So I'd love to introduce Jen and hear from you, Jen, just about your perspective on the changes and how this has impacted, in particular, methadone access, since we've heard so much about buprenorphine already.
Sure, thank you, Sarah, and hi, everybody. Thanks, IHRC, for this invite and opportunity to speak. Dr. Lynch and Monica are certainly tough acts to follow. They've covered a lot of the barriers and things that I do have listed, but hopefully I'll be able to touch on a few additional things. And I will tell you that I do have a basset hound that is snoring behind me, so I apologize if you hear that during this presentation. So UCS Healthcare is the largest opioid treatment program in the state of Iowa. And for those of you that don't know, an opioid treatment program, or OTP, is a facility where patients can see a prescriber, receive their medication, and attend counseling all in the same facility. OTPs are able to administer methadone as well as FDA-approved medications for opioid use and alcohol use disorder. So over the last 2.5 years, we were able to rapidly expand medication-assisted treatment with the help of Iowa Department of Public Health's state opioid response funding. So this funding allowed several behavioral health providers across the state of Iowa to partner with us to bring a medication unit into their treatment facilities. And over the last 2 years, UCS has created better access to MAT by opening 2 additional OTPs outside of Des Moines, and 11 medication units in as many counties throughout Iowa for a total of 14 locations. Des Moines is our main location, and there we provide medication-assisted treatment, outpatient substance use disorder treatment, mental health, psychiatry, family practice services. We're licensed by the state of Iowa and accredited by CARF. So during COVID-19, we have seen a slight increase in MAT admissions over the last couple of months. I would say that some of the positives I just want to echo are the telemedicine and telehealth that our providers are able to use and get paid at the same rate as in-person visits. This has created a huge positive for us because we have prescribers that have underlying conditions, and one prescriber that was pregnant at the time. And so for them to be able to see patients without feeling as if they're at risk for their own health by telehealth has been a huge positive. So it's not only just a positive for the patients, but it's also a positive for our prescribers and keeping everybody safe. Unfortunately, we do still have to do in-person admissions for beginning methadone medication. So that is a regulation that did not change with COVID-19. So our prescribers are still having to do in-person for that initial admission evaluation for that medication. I would say that telehealth and audio-only counseling and therapy has helped to decrease our no-show rate for our individual sessions by 7%. And the patients are telling us that they feel more comfortable at home. They get to have their dog or their cat on their lap while they're having a session. It makes them feel comfortable. Transportation is no longer an issue, and that travel time is no longer a factor. So as Dr. Lynch had talked about, some people are traveling an hour each way to meet their providers. I would say that we were given the ability to give additional take-home medications. So remember I talked about as an OTP, we actually administer the medications within our facilities. So our medical director was able to take a look at our patient caseload and identify what he felt was kind of a stability threshold, where he felt that it was okay to give additional take-home medications. And we were able to give over half of our patients those additional take-home medications during COVID-19. Even patients that are maybe coming up showing positive for low levels of THC were given the ability to get additional take-home medications. And before COVID-19, patients receiving methadone would need to present to the clinic for their medication daily for the first 90 days. So being able to identify when a person is stable, maybe before that 90 days, has been extremely beneficial to both patients and prescriber to get people just able to do normal activities. It's difficult to have to present to a clinic daily when you're also trying to hold a job and go to school or, you know, have social connection. I did do a little bit of research before I came on to see what we were seeing with medication adherence. So I mentioned that we had about 50% of our patients that were giving these additional take-homes. 92% of those patients were able to continue with appropriate medication adherence up to this point. So it's been extremely successful. So there have been just a couple of negatives. Again, I would reiterate, some patients do have poor internet access, poor broadband, or limited phone data and minutes. Monica had mentioned that we were given the ability to deliver medications to patients' homes. That has been great for keeping everybody safe from COVID, but it has been a little bit challenging, and staff has had a little bit of safety concern in doing something like that. Let's see. And then I think it was said also, but the patients do miss social interaction. We have had several patients say that they do miss the in-person and hope that we get back to group therapy in person soon. I will say our group attendance has decreased by about half. Now that's partly because we had to limit some of the sessions that we were giving just because of transitioning. But I do believe that it is difficult in a group session sometimes to participate if you don't feel comfortable. So I guess all in all, the recommendations that I have are that we should be able to give people options to how they want to access care. They should be able to access care through audio, through video, in person, but we should just give them options. And then also maintaining the same reimbursement rate for those visits is so important for our facilities to continue providing services to the communities. The additional take-home medications, again, that's just been such a positive. Just relying on our prescribers' clinical judgment to identify when patients should receive these additional medications, it is just so important and just seems to make sense. I would say that there's one other thing that I didn't really touch on, and this has kind of been something before COVID too, but we need to look at more diversion programs away from jails. Not all of our jails accept patients to take their medications, their MAT medications within jails. And that's a huge problem for people. They will go into withdrawal. They don't have appropriate medical supervision as they are withdrawing off of their medication. So I did just want to throw that in here, that more diversion programs, jail diversion programs would be beneficial. Let's see. I think that I've covered just about everything that hasn't really been covered by anyone else. So thanks again.
That was awesome. Thank you so much, Jen. Just moving right along, just for sake of time, we do have a couple speakers left. So we are delighted to have Evelyn join us. And I'm sorry, there's a typo in Evelyn's bio that I didn't address with her first name in the bio here. But Evelyn, anyways, so happy to have you here as the General Counsel for Health Policy in Senator Charles Grassley's office, or Senator Chuck Grassley's office. Can you tell us a little bit about the federal perspective, especially from the legislative standpoint on, it sounds like what we've heard so far is that these changes are all helpful and have been beneficial to patients, but barriers still remain. Can you tell us how the federal government can be working to address some of these remaining barriers and make sure that these revised regulations stay in place?
Thank you so much. Can everyone hear me okay?
Yes.
Yes. Okay. Well, the effectiveness, safety, and availability of the three main drugs used in medication-assisted treatment of opioid disorders is of great interest to Congress in trying to address ongoing opioid crisis in the U.S. Naltrexone, of course, is injectable that blocks an opioid's effect, and it's considered new and promising, but we're still trying to understand the science behind it. Also, you have to be clean for at least 7 days to use it, so it's limited to people who have stabilized. It doesn't carry an addiction risk, so it's not regulated under the Federal Controlled Substances Act, unlike buprenorphine and methadone. Buprenorphine, of course, it's not as strong as methadone, and it's a partial agonist, so it's believed to have fewer dangers than methadone. It also lacks the euphoric properties. There are caps on the number of patients a doctor can see. I think it's about 100 in the first year and 271 after that. Methadone, of course, is mostly administered on a daily basis, and it has to be administered through a certified treatment program. The Substance Use and Mental Health Services Agency, or SAMHSA, is responsible for certifying providers, and the Drug Enforcement Administration, or DEA, has to license them, as both these drugs, methadone and buprenorphine, are regulated under the Federal Controlled Substances Act. With respect to methadone and buprenorphine access, Congress and the administration have done three things mainly in recent years to make them more accessible, and our presenters have already covered much of this. But Congress did, and this has not been mentioned, increase access to buprenorphine by expanding the category of people who can prescribe it. I think there's a 5-year period now in which nurses, and not just physicians, can provide medication-assisted treatment. And this was done through a measure known as the SUPPORT Act, or the Substance Use Disorder Prevention that Promotes Opioid Recovery and Treatment for Patients and Communities Act. It's Public Law 115-271. It was a broad measure with many provisions to address overprescribing and abuse of opioids in the U.S. But it did include that one provision, which is very important given the shortage of physicians in rural areas. Second, Congress, as part of the COVID-19 relief legislation, made telehealth much more accessible. And the Department of Health and Human Services has taken advantage of the new statutory authority. As already mentioned by Dr. Lynch, buprenorphine can now be provided from home through telehealth without an initial visit to a brick and mortar facility. Methadone, of course, still requires an in-person visit. The executive branch also provided waivers of federal privacy requirements that made it much easier to extend substance abuse treatment through telehealth. First, it relaxed CFR Part 2, which is a privacy rule relating to access to behavioral health and substance abuse records. It also relaxed the privacy requirements that ordinarily apply under the HIPAA statute through administrative action. basically HIPAA, or the Health Insurance Portability and Accountability Act, requires healthcare providers to abide by data privacy, data security, and data breach notification requirements in treating certain medical information. So, these restrictions are for privacy and security reasons, but they also limited healthcare providers' ability to offer telehealth services. So the Department of Health and Human Services recently announced during the COVID epidemic that it won't be enforcing HIPAA's requirements against healthcare providers who are engaged in the good faith provision of telehealth during the emergency, and regardless of whether those services are related to COVID-19. The third thing that Congress has done is conduct oversight on opioid-related topics, and meanwhile, executive branch agencies have been focusing on research and the collection of data. To illustrate, some of our colleagues in the House of Representatives announced this morning that they're doing oversight of the Federal Communication Commission efforts to help extend telehealth during the pandemic, because there's some areas that are facing obstacles in actually accessing the internet. Also, during the last 3 or 4 years, a number of different congressional committees have held hearings on opioid-related topics, like implementation of CARA, the effects of the opioid crisis on families, opioid use among veterans. Senator Grassley, my boss, for example, convened a hearing last year on the 1-year anniversary of the Support Act on scams and addiction treatment and the stigma surrounding addiction. We heard from a couple of different watchdog agencies, the Surgeon General, and a nonprofit about sober homes and other scams in which fraudsters have been preying on people with addiction. And there have been, I think, over 150 bills introduced in recent years relating to opioids. As far as what's next, there are a couple different things we need to decide. First, we definitely need to continue our congressional oversight in this area and continue to collect data on what works best to treat addiction. For example, we're still monitoring implementation of the Support Act, which was enacted only about a year ago, and we don't yet have data on how these current COVID-19 waivers are working in practice. And we also should look at data to determine if the pandemic is worsening the opioid crisis, as it probably is. Second, we need to better understand why providers who do already have data waivers or X waivers aren't prescribing at capacity. The Substance Abuse and Mental Health Services Agency did a 2018 study on this, and they found that just 13% of those with these waivers were prescribing at capacity. And that's a very low percentage, which raises two questions. First, are providers where they're supposed to be? That is, are those with X waivers in areas with low rates of substance abuse disorders? We do know in rural communities there aren't enough physicians to prescribe buprenorphine. And the second question is, are many providers not seeking to treat substance abuse because of the stigma surrounding it? We also need to decide, after the COVID-19 period ends, should we extend all the telehealth waivers and flexibilities beyond the pandemic period? Should we extend some, but not others, or return to the past situation? People are really divided. We also, at some point, may want to extend the 5-year period in which not just doctors, but nurses can prescribe MAT. And then we should consider possibly use of non-video options like telephones, as someone mentioned, for reimbursement parity. That's something that Congress will have to decide what to do. And I've heard from think tanks in Washington that we should consider trying to encourage behavioral health conversations as part of primary care visits so that buprenorphine treatment can come up at that time. And that's all I have.
Wonderful. Thank you so much, Evelyn. So now I am delighted to introduce Anna Bonelli, who is with CMS, the Center for Medicare and Medicaid Services within the federal government. So Anna, can you tell us a little bit about how CMS is planning to address this regulatory issue in the future, and how CMS will need to work with states to continue optimizing that access?
Sure. Sarah, can you hear me okay?
Yes, you're perfect.
Okay, great. Well, thank you. First of all, thank you so much for having CMS on this call. I think, it's awesome seeing the continuum here of different speakers who have a different role to play in addressing the opioids crisis. So I'm from CMS, it's the Center for Medicare and Medicaid Services, and as has been alluded, we're one of the federal agencies within HHS that has an important role to play in ensuring that that people have access to the care that they need, as well as expanding access during the COVID crisis. We are not solely responsible for permitting more telehealth, but as others have mentioned, we're one of 3 agencies, DEA, SAMHSA, and CMS all have an important role to play in ensuring that beneficiaries in Medicare and Medicaid can have access to their buprenorphine, their methadone, et cetera, via telehealth, as well as their counseling and so on, via telemedicine, and get paid for it. So that's our special role, is to ensure that when providers are complying with the rules, that they can be reimbursed for all of these services that we're discussing. So Sarah, you asked me some specific questions. I have some talking points, and I'll set them aside in the interest of time right now and just respond to your questions a little bit more directly, maybe. And again, kind of try to knit some of this discussion together. What we're working on right now is exactly what you're describing. How can we make sure to continue telehealth policies that are worthwhile, and that are beneficial to our beneficiaries? We have to weigh a lot of things, so we've got 2 major programs here that we're talking about, so I want to be sure that we separate the 2. We've got Medicare and Medicaid. Medicare is much more of a federal program. We have a lot more ownership over it, and we can directly write rules that regulate, to within statutory limits, what services are provided and how they're provided. We have a fair amount of flexibility there, and we have to do that through rulemaking, which, as you know, takes a long time. In the last several months, we've issued 2 sort of emergency rules called interim final rules that have waived a lot, or have changed a lot of our policies on telehealth. Those, normally can take us over a year, sometimes many, many months to issue, and we did them within a few weeks. We've also issued over 130 blanket waivers, nationwide waivers that cover not just telehealth, but other things like increasing capacity at hospitals and other types of facilities to deal with, surging cases. And so within all that, as I said, we have to figure out for Medicare what we're going to continue in the future and what we're going to dial back. We're weighing things like, the cost of services, the quality that we see as being provided, and we have to weigh what the statutes permit, given that, we've had authority to issue some waivers because it's a public health emergency declared by the President and the Secretary of Health and Human Services, but we don't have unlimited authority to continue all of these policies forever. We would need some statutory changes to continue some of them. So that is a process that needs to go largely through rulemaking, which takes a really long time. So we're at the beginning of that process, and we'll be seeking comment on a number of these different policies. And so the public will have an opportunity, as all you will, to weigh in. On Medicaid is a bit different. So Medicaid, also an extremely important payer in the space, covers a tremendous number of people with OUD and SUD. And Medicaid is a state and federal partnership, so it's very different. We don't have as much authority to regulate what services states provide and how they provide it. States in these circumstances have a lot more of their own authority. States have broad flexibility to provide services via telehealth and to pay for those services at parity with in-person services if they so choose. But again, that's something that CMS would examine the state's policies and approve or disapprove, if they're in compliance with federal statutes and regs. But it's not something that we can be directive about. So Medicaid programs are going to continue to all be different across all 56 programs nationwide. And, that's not going to change. But I think it probably stands to reason that a lot of states are going to continue some of their telehealth policies, but that remains to be seen. Sarah, why don't I stop there? I can go on and on about a number of other things, but I'm trying to be responsive to your questions right now, especially given the time.
I really appreciate that. So it looks like Shannon is not with us. Shannon, let us know, I guess maybe in the chat if you joined through the attendee link. But otherwise, I know, so Shannon is a representative and the chair of the Human Resources Committee in the House of Representatives in the Iowa State Legislature. And the legislature has been convening this week and is quite busy and working late into the night every day. So I think Shannon will not join us after all. And so I want to go into just a quick moderated Q&A. And so I'm just going to ask one question, and then I'll open it up for folks to join us in the audience. So if you have a question and are with us, please drop it into the chat. And I want to pick up on a couple of discussion that has been going on in the chat a little bit and bring it back to Chad's mention that he had some experiences to share. And so what I'm wondering if speakers will talk about and can think about is the role of telehealth access in addressing disparities, especially between Black patients and white patients, where the disparity is greatest, and who make up a larger percentage of people with opioid use disorders in Iowa. If you can talk about the potential for this model of access to reduce the disparities in prescribing rates and rather than disparities, I should say inequities, but inequities in prescribing rates and in the experience of systemic racism that patients can encounter when they come to the healthcare setting ordinarily. So Chad, do you want to speak to that a little bit?
Yes, I will speak with that. Just so I am super clear, would you give me that vocabulary of disparities?
Say that one more time.
What do you mean by disparities?
So I mean, that's a good question. I mean inequities, and so I mean differences in rates. And so there's a national study that says that white Americans are prescribed Suboxone at 35 times the rate of Black Americans. So
yeah.
Huge disparity.
Yeah. So there is. I have a lot to say on that, but I'm gonna try to keep it to a minimum. But I really don't like to get too far into that field because people have different opinions, and some people don't believe facts, and studies. But here we have a situation where minorities are exposed to these drugs at a younger age on the street, and they end up continuing their usage throughout their life, or they find easier ways to use and abuse, and that could be medically or still on the street. And then you have non-minorities, I'll say let's just say white folks, and I'm not pointing fingers or anything. I'm not here to do any of that. I'm here to make progress so we can make change, just so everybody understands. But yeah, let's say let's say white folks, they get into things at a younger age, and this is just from my personal experience. My family owns event party planning and vape shops, CBD shops, dispensaries. So we are in the field of helping people get away from prescription drugs and whatnot. And it seems that Caucasians have much easier access to narcotics that are medically prescribed or need a prescription, and and I I am not exactly sure why they have that access, because um, I am not Caucasian, but I can assume, um, and my assumptions aren't proven, so they aren't fact. But my assumption is just because there is a slight problem in the world in general, and that's that doctors aren't black. You know, doctors aren't black or Hispanic. They uh, tend to be Caucasian or Indian. Um, you do have, you know, a few African, but they're not Black Americans, and that's where I do see a slight issue with minorities getting the treatment that they deserve and they need, so they can be a productive part of society. And everybody should want addicts in America to change their life so they can be productive. That's the only way that we are going to move our country into the future, is getting everyone proper health care, easily accessible, and fairly.
Chad, I think you bring up a really good point, that a lot of healthcare disparities can flow from, or sorry, I keep saying disparity, but mean inequity, that they flow from a lack of representation in the workforce. Can other folks, other speakers and panelists speak to this question and talk a little bit about the opportunity of telehealth to address disparities and to address systemic racism and its impacts?
Hi, this is Jen. I will just speak a little bit about this. Obviously, it's something that we've been thinking a lot about. I think that one of the issues, I would agree with Chad, that minorities just aren't represented in a healthcare environment as much as they should be. And I think that part of it has to do with just stigma. There's a lot of stigma around treatment and addiction in minority communities. And then there's just, because of that, there's no trust in treatment providers to help with these. So if we could somehow gain some more trust within the minority communities and provide them with ways to start accessing education and these healthcare careers without going into massive debt or being able to access them at all with grants or some sort of funding for that education, I think all of that will help. Yeah, I completely agree with what Chad had said. And then again, I'll just mention that the jail diversion programs, I think would be a good starting place, instead of criminalizing drug possessions. Just divert those patients to treatment facilities instead would be a good start.
Or divert them to whatever resources they need, or social workers, or whatever is in line with their personal goals.
Exactly, more of a community response.
Do the other panelists want to comment on this issue?
Chad here again. I'll say that from personal experience, the um, the jail assisted treatment is very important. You can see in other countries that that they reduce the amount of people that they have in their jails by um, by making sure they get the treatment they need to make sure that they're in a mental state where it doesn't happen again, or a financial state where it doesn't happen again, or they have housing so they're not trespassing somewhere just trying to get out of the rain, um, and they get arrested uh, and sent to jail, just for trying to get out of the rain. So making sure that people get the treatment that they need instead of locking them up and using that taxpayer money um, is a large thing that I think would benefit the country quite a bit.
One other thing to note that some in the community outside of this presentation today have mentioned is that many healthcare disparities, their existence is related to systemic racism and to an experience within the healthcare system that can cause many patients, especially who are Black folks, to experience discomfort and unease, and as Chad noted at one point, fear when accessing healthcare, and especially when visiting a hospital or clinic. And so some have noted that perhaps this telehealth model for MAT may allow patients to feel a greater sense of comfort and reduce fear of interactions with healthcare providers because they are not physically within that particular space. So I'd like to just address one of the questions that is in the chat. And I'm wondering if folks can talk about the urine analysis requirements that are tied to MAT and how providers have navigated this and what sort of the regulatory future looks like for patient requirements for UAs. And please feel free to return to my previous question as well, but go ahead.
Great. This is Monica Wilkie-Brown with IDPH, and I just wanted to mention, related to kind of the last question and conversation, that we have been working pretty consistently over the last few years with the Department of Corrections at the state level, and they do have leadership support for medication-assisted treatment within the walls of the state correctional facilities. And I think that our grantees who have been working with corrections, of course, it's been a little more challenging through the COVID time, but in general are finding a slightly higher level of cooperation from the state correctional facilities and staff. I think, each facility still has a fair amount of education and training to do with some staff people who may not be as aware of, the most recent research and best practices, and therefore might not be as open to medication-assisted treatment. But we do hear from our providers also that they have struggled a bit with county jails, because county jails are run on a much more localized level and don't have consistent rules or leadership across the state, I should say, as far as ability to provide medical care in general, but medication-assisted treatment specifically within local county jails is pretty different across counties. And that's something that, we have been trying to see what can be done and how to do it to make things more accessible and more consistent across the state. But that is definitely one of the challenges.
Thank you. To other folks in our last minute remaining want to address the question about UAs?
This is Allison. I put this in the chat, but I normally am doing urine testing when people are coming into our clinic, and I have not been doing it with our telehealth visits, except that I have had a few patients who wanted to get tested for various reasons. But I feel like that's there is definitely some value of doing urine testing, but it's asking people to figure that out locally is a challenge, and I feel like that's something I'm still trying to figure out what the best options are. And I wouldn't make it a requirement if there are a lot of barriers for somebody to get testing at this point.
So I'd like to just be mindful of time and acknowledge that we are exactly 90 minutes. And so just out of respect to presenters and to our attendees today, I want to thank all of you for joining us. And I want to just take one final minute to ask speakers for any last thoughts that they might like to add to the discussion just while we have everyone here today. And then with that, we'll go ahead and close. So I appreciate very much everyone for joining. And so we will be posting this webinar to our website and distributing it via our listserv and social media channels. You'll also be able to see a written summary of highlights from the webinar soon. And we're excited to share future upcoming webinars with you on this topic. Any final thoughts from our speakers? Well, with that, that concludes our webinar today. So we'll go ahead and end this session and look forward to continuing this conversation with all of you in the future as we see this landscape evolve